Seborrhoeic dermatitis. Our next topic is seborrhoeic dermatitis. We are done with atopic dermatitis, dermatitis herpetiformis, contact dermatitis. Now, the next type is seborrhoeic dermatitis. So, in dermatology, it is very important to focus on the name of the disease. If you focus on the name of the disease, you will get some hints about the disease. So, seborrhoeic dermatitis is basically a dermatitis of sebum producing, seborrheic for sebum producing areas. So the main presentation will be greasy areas, because it is a dermatitis of sebum rich areas. So the person presenting feature will include greasy areas of redness with scaling. So this will be a main feature that will help you in diagnosing seborrheic dermatitis. Just give me a minute. So seborrheic dermatitis, it is a rash, a scaling rash that present to you with greasy areas with fine scaling. So greasy areas, red greasy areas with fine scaling, you will think of seborrheic dermatitis. So remember this diagnostic point for seborrheic dermatitis from its name. Seborrheic dermatitis is a chronic dermatitis that is thought to be caused by inflammatory reaction to proliferation of a normal skin inhabitant. So normally a fungus that is Malassezia furfur, that is a normal inhabitant of the skin of the sebum producing areas or sebum rich areas. It is basically the seborrheic dermatitis developed due to an inflammatory reaction to this fungus. What are the examples of sebum rich areas? Scalp, periorbital, auricular, and nasolabial fold. So in head, these areas can be affected, such as scalp, periorbital, auricular, and nasolabial folds. Also, it can lead to otitis externa and blepharitis. When a scalp is involved in seborrheic dermatitis, it may cause dandruff. Associated conditions are Parkinson disease and HIV. HIV, because in HIV there is immunity is suppressed, so this Malassezia furfur, it overgrows, and therefore an inflammatory reaction is developed to this fungus. Now, what is the management of seborrheic dermatitis? Management is very simple. If scalp is involved, and then over-the-counter preparation that contain zinc pyrithione, such as Head and Shoulder shampoo, and it is considered first line. If scalp is involved and the person present to you with the dandruff, suspecting seborrheic dermatitis, then zinc containing shampoos such as Head and Shoulders, they are first line. And if patient does not respond to this Head and Shoulder, then the second line is because it is a fungal infection. Then the second line agent is ketoconazole. Selenium sulfide and topical corticosteroids, they may also be useful. And if there is involvement of the face, then we can use topical antifungal and topical steroids for a short periods of time as well. The mainstay of treatment in both the cases, in the scalp management, the first line is Head and Shoulder and second line is ketoconazole. While in face and body management, first line is topical ketoconazole. So dermatitis in sebum-rich areas such as head, ear, and eyes is known as seborrhoeic dermatitis, and the presentation will be red greasy areas with fine scaling. The management is topical ketoconazole. So this was all about seborrheic dermatitis. Is it clear, everyone? Our next topic is psoriasis. So atopic dermatitis or eczema, the rash of eczema or atopic dermatitis, it was present mainly in the flexor areas. While the rash that is present in psoriasis, it occurs on extensor surfaces of the body. So this is one difference that you need to remember between psoriasis and seborrheic dermatitis and atopic dermatitis or eczema. So psoriasis is a chronic skin disorder. Uh, it is basically a multifocal disorder and is not yet fully understood. There's a genetic factor, immunological factor, and environmental factors. All of these can lead to the development of psoriasis. There are four subtypes of psoriasis. One is plaque psoriasis, second is flexural psoriasis. Then there is a gutted psoriasis, and then is pustular psoriasis. You only need to focus on plaque psoriasis and gutted psoriasis because they are commonly tested in the exam. Psoriasis, remember that the dermatitis or the rash in psoriasis is associated with nail changes such as pitting and oncolysis and arthritis as well sometimes. And the type of arthritis that occur in the psoriasis is seronegative type of arthritis. The complication of psoriasis it include psoriatic arthropathy. It is present in around 10% of the patient. There's also an increased incidence of cardiovascular disease. There's also an increased incidence of venous thromboembolism, psychological distress, and increased incidence of metabolic syndrome as well. Exacerbating factors for psoriasis include trauma, alcohol, and some drugs such as beta blocker, NSAIDs, anti-malaria, lithium ACE inhibitors, etc. One important point that you need to remember is that streptococcal infection may also trigger gutted psoriasis. So in all the chapters, we discuss some diseases that usually occurs after a history of upper respiratory tract infection or sore throat. For example, in hematology, we discussed that hematuria after upper respiratory tract infection is due to post-streptococcal glomerulonephritis or IgA nephropathy, or it can be due to idiopathic thrombocytopenic purpura. So in skin, remember that two conditions you need to remember in the dermatology chapter that can occur after a history of sore throat or upper respiratory tract infection. The one of them is gutted psoriasis. And the second one is psoriasis rosacea that we are going to discuss in the coming slides. For now, just remember that gutted psoriasis, which is a type of psoriasis, can be triggered by infection with streptococcal. bacteria. So you can see that red plaques with white scales over them. You can see these red plaques, and there are white scales over them. And this plaque is present on the extensor surface of the elbow. This is a type of plaque psoriasis. So red plaques, or well demarcated red plaques on extensor surfaces of the body with white scales, you will suspect psoriasis or plaque psoriasis to be more precise.
So in gutted psoriasis, there won't be any plaques, or it's just
In
that.
gutted psoriasis, there are teardrop shape or teardrop lesions or teardrop redness. Gutted psoriasis will discuss in detail in the um, coming slides. Yes, you're right. There will be no plaques in gutted psoriasis because this name is specific for plaque psoriasis. The lesions in plaque psoriasis, they are bigger, while in gutted psoriasis, the red lesions, they will be smaller, just like teardrops.
Right.
So the management of psoriasis, it include in this slide a detailed management of uh, psoriasis is given, uh, which is usually not required for Plab 1. But still, you can remember it. 4 drugs can be used in the management of psoriasis, and they include steroids, topical steroids, vitamin D analogs, coal tar preparations, and dithranol. So these are the 4 drugs which are used in the management of psoriasis. Steroids, vitamin D analogs, coal tar preparation, and short-acting dithranol. First line is steroids once daily and vitamin D analog once daily. And if there is no improvement, then after 8 weeks, we can increase the dose of vitamin D analogs to twice daily. And if still there is no improvement, we can add coal tar preparation, applied once or twice daily. So first line is steroids once daily, vitamin D analog once daily. Second line is if there is no improvement with this regime, then we can increase the dose of vitamin D to twice daily. And the third line is we can add coal tar preparation as well. If there is no response with a potent steroids and vitamin D analogs, then we can add coal tar preparation as well. Dithranol can also be used as a treatment option. Remember that steroids are used only for a short term in the management of psoriasis because they can be absorbed into the blood vessels and can result in systemic manifestation of steroid overdose. That's why long-term use of steroids is avoided. Topical steroid can all lead to skin atrophy, stria, and rebound symptoms. Systemic side effects may be seen when potent steroids are used on larger areas. For example, if more than 10% of the body surface area is involved, then using steroids can result in systemic side effects. NICE recommends that we aim for a 4-week break before starting another course of topical steroids. So steroids are used for 4 weeks, and then uh, a gap of or a break of 4 weeks is given, and then we can think of restarting the steroids again. Potent corticosteroid for no longer than 8 weeks at a time, and a very potent corticosteroid for no longer more than 4 weeks at a time. So, what are the examples of potent corticosteroids? Potent corticosteroids, they include mimetasone and beta-methasone 0.1%. So they can be used for 8 weeks, while clobetasol, that is a very high potent steroids, it can be only used for a period of 4 weeks at a time. What is the mechanism of action of vitamin D analogs? A mechanism example of vitamin D analogs, they include calcipotriol, calcitriol, and uh, taclicalcitol. The mechanism of action is that they work by reducing cell division and differentiation. So they inhibits the cell growth, and they can be used for a longer duration of time, unlike steroids, and they have no smell or they do not stain, unlike coal tar and dithanol. So you can say that it can be used for a longer duration of time, and there is no smell or there is no staining with the use of vitamin D analog.
What is the meaning of rebound symptoms?
Rebound symptom is that while using steroids, the patient's symptoms can get worse with the use of
Right.
steroids.
Right. So these vitamin D analog, are they in the form of preparations like creams or
Yes,
ointments?
yes,
Right.
yes. They are topical agents.
Right.
Now, secondary care management can include phototherapy, photochemotherapy, and systemic therapy. In phototherapy, ultraviolet B light is used, and it is given 3 times a week. In photochemotherapy, a chemical such as soralin and ultraviolet A is used. And the side effect of this phototherapy and chemotherapy is skin aging and squamous cell carcinoma can also develop as a complication of these procedures. And if the person has, along with skin involvement, there is psoriatic arthritis as well, then oral methotrexate can be used as a first line systemic therapy for psoriasis if the person has associated arthritis as well. Dithanol and coal tar, they both inhibit DNA synthesis, and calcipotriol, it inhibits the proliferation of cells. You can see as an example, because there's excessive proliferation of epidermal cells in psoriasis. So vitamin D can help in uh, reducing the growth of these cells and reducing the symptoms. You can see in this diagram that after application of vitamin D analog, the scales has disappeared. So this is the effect of vitamin D analog. But vitamin D analog, you can see that has no effect on the redness or erythema. For that, we can use steroids. So this was all about psoriasis and its management. I hope it's clear to everyone. If there is any question, you people can ask.
If the patient has plaque psoriasis, some of these they develop arthritis and joints pain. What is the cause of that?
Arthritis is due to autoimmunity, that the immune system, it start to react against the synovial membrane that is present in different joints.
Right. Thank you.
Any more questions?